Welcome to the eMedica National VTS GP Trainee Teaching Session 9. We'll start with AKT revision. We're going to do 3 questions, 1 clinical, 1 stats, 1 admin. Then we're going to do an update on the RCA and examinations for people in the final year of training, and we'll do some consultation skills. And finally, the last session is GP trainee money tips. We're going to look at 5 ways you can increase your take-home pay without doing any more shifts, without doing any extra work. You're already busy enough and working hard enough, okay? So ways you can actually save money without working more, all right? So let's start with some AKT. We're going to do 3 high-yield questions. You'll have 57 seconds to look at the question, then the poll will come up, okay? Here we go. Okay, great. So most popular answers are A, B, and F. So FSH level, FSH-LH ratio, and no investigations necessary. These were the 3 most popular answers. A few people picked thyroid, ultrasound, or testosterone, and a couple of people GH or I, which aren't even options here. Okay, great. So now this is an example of what we call a 2-step question. The answer is for the second part, right? Working out the appropriate investigation, which means appropriate for this patient in this situation. But the first step is working out what is the thing that you're trying to rule in or rule out, i.e. what is the sort of differential or the potential diagnosis that you're trying to look at if you need to do a test, or which test is going to help you confirm that. So I'll just open up the chat again. What do you think the possible diagnosis is? Imagine we could have the same exact question, and instead of asking about tests, the options could be a list of diagnoses here. Okay, so just type into the chat, what do you think the diagnosis could be? What do you think might be going on with this lady? I'll give you a second to type that into the chat. Okay, so some people have said early menopause, some people have said menopause, some people have said perimenopause. Okay, so you're all along the right lines and that you're thinking about the right things, but which one of those 3 do you think it is? Do you think it's early menopause? Do you think it's perimenopause? Do you think it's menopause? Okay. Good. Well, that would make a good question in itself. Okay. So the actual answer as to what the diagnosis is for this scenario is this is perimenopause, isn't it? Okay. So what's the most appropriate test? That's the question. The correct answer is F. No tests are necessary. Okay. And I just wanted to highlight something really important, that in real life general practice, and therefore in the exam, there are often scenarios where you don't need to treat anyone because they've got a self-limiting illness and all they need is reassurance. You don't need to do any tests. You don't need to start any treatment. Why? Because there's lots of things in medicine where that's actually the right thing to do. And the examiners have highlighted that doctors often struggle. Less than half of you got this question right. Okay, so most people got it wrong. About 44% got it right. That sometimes doctors, while they might think that F was the right answer, was there anyone, be honest, let me know in the chat, that you thought it was F, that's what you were naturally drawn to, but then you thought, that's a bit too straightforward, there must be something. And you thought, I better pick something, so I'll pick A, FSH. And so you change your answer from the right one to the wrong one. People often do this in the exam and lose marks. Do this a few times out of 200 questions, lose a few marks. Could be the difference between pass and fail. Sometimes the right answer is not to do anything. And what you need to do is do what is the right thing for the situation, not try to second guess yourself. You need to have some confidence in your own knowledge and to know the guidelines and know what would be the right thing to do for a GP, and it's going to help you get the answer right. Okay, so we don't need to do any tests here. Why? Because she's got typical vasomotor symptoms and she's over 45. So look, 46 years old with irregular periods. Typically, when you're in the perimenopausal phase, your periods, they become irregular. Sometimes they shorten, so they'll go to 2 to 3 weeks. Sometimes they lengthen, 5, 6, 7, 8, 9 weeks, even 12 weeks, even longer. Okay, all of this is possible. Couple of other clues here, that she's had 2 UTIs, it looks like, in the last sort of year. And one of the things that happens in the perimenopause and the menopause is that actually there's an increased chance of getting UTIs. And she's got the classical vasomotor symptoms, hot flushes and excessive sweating. Okay, and then a couple of other things that are really, really important that help us not to want to pick up this. For example, the fact she's had no changes in weight, because if she'd, for example, had a significant loss in weight and we were worried about things like cancer, sometimes that can present with funny symptoms. If she'd had changes in weight, we might have thought about things like thyroid. Then it might be appropriate to look at, things like thyroid function tests. Do you see what I mean? So the fact that there's nothing else there, she's got typical symptoms and is otherwise healthy. There's no red flags. There's nothing that points to any other specific diagnosis. That's why the right answer is F. Okay, so no investigation is necessary. So perimenopause. When to suspect perimenopause? If someone's got a change in their menstrual pattern, now that could be that it's become shorter than usual, or longer, or some months shorter, then flitting between shorter and longer. And the blood loss, it may be that often it becomes a bit heavier actually, but sometimes it also goes the other way. It can become a bit lighter. It's very, very unpredictable. That if they've got that, you should suspect it. And what's going to help you confirm it is to look at the symptoms associated with the menopause. That brings me to the next question. What are the typical symptoms of menopause, which you can also get in the perimenopausal period? Okay, so what are the symptoms you'd be asking for in your history? You'd be specifically looking to rule in or rule out when you see a patient like this in general practice. Okay, just type that into the chat. What are the symptoms, the menopausal symptoms that you should be asking about, that you should be looking for? Okay, so someone said mood swings. Yeah, so irritability, mood swings, definitely. Someone's mentioned dryness, so vaginal changes such as atrophy and dryness. Someone's mentioned lack of sex drive. So yeah, changes in libido, loss of libido, sexual dysfunction. Someone's mentioned about brain fog. Yeah, absolutely. So you can get cognitive changes, things like poor concentration, feeling a little bit foggy. Okay, that's sometimes how the patient will describe it sometimes, that they can't multitask in the way they used to be able to. Someone's mentioned joint pains. Yeah. What are the classical vasomotor symptoms? So hot flushes. Yeah. Excessive sweating, especially at night. Yeah. Someone's mentioned because of dryness that they might get dyspareunia, so painful intercourse. Yeah, absolutely. Memory loss. Yes, great. Okay, great. So well done. Between you, you've got pretty much all of them. So let's just recap what they are. So we can split them into category. So if we look at the vasomotor symptoms, so the classical ones are the hot flushes and excessive sweating, sometimes palpitations. The sweats are often worse at night. Cognitive impairment and mood changes, so things like poor concentration, memory changes, finding it more difficult to multitask. And then mood changes can be from anxiety to low mood to mood swings, being labile in mood, to being excessively irritable. Sleep disturbance you can get because of night sweats, but you can also get sleep disturbance as a separate symptom without sweats. Okay. Urogenital symptoms, so vaginal dryness, okay, that can make it more painful to have intercourse. And then altered sexual function, actually losing libido. Do you see they're two different things? So this can make it more difficult to have intercourse, that it can be painful or there can be bleeding. And this can make it that they lose interest, they have a low libido. And as a result also of the urogenital changes, that's one of the reasons why there's an increased risk of getting UTIs. Okay, so well done. So these are the symptoms you'll be looking for. So just to recap, diagnosis. The NICE guidelines specifically say that you should not routinely use blood tests to diagnose perimenopause or menopause in women who are over 45, like this lady, who are not on hormonal contraception, she had a copper coil, and who are otherwise healthy, i.e. there's sometimes where doing a test is the wrong thing. Okay, the right thing is not to do any tests at all, but you can just diagnose it based on the clinical appearance, the features that we've seen. So perimenopause, if they're over 45, not on hormonal contraception, otherwise well, if they've got vasomotor symptoms and irregular periods, you can make a diagnosis. Whereas few people had said menopause, to diagnose that, as well as the fact that they're, over 45, not on control, you need to make sure they've had no periods at all for 12 months or more. Okay. If you've had a lady who hasn't got a uterus, then you could just base it on symptoms. Okay, because you're not going to have that thing about the periods there. Okay, and then when should you consider, because quite a lot of you picked FSH measurement. That was like the second most popular one after the correct answer was to do FSH measurement. So when might you use that to diagnose menopause? If you've got someone who is not on the combined oral contraceptive pill or not on HRT, and they're over 45 but with atypical symptoms, so they don't have the typical symptoms, then you might do it and it might help you diagnose. If they're 40 to 45 and they've got menopausal symptoms, then you might use it, okay, because that's quite young. If they're under 40 and you're suspecting POI, premature ovarian insufficiency, then you might use it. And then if they're 50 plus and they're using a progestogen-only contraception, again, this lady had a copper core, she wasn't on any hormonal contraception at all, then you might consider FSH measurement. Right, good, well done. Let's move on to the next question, which is on stats. Here you go. And this is a multiple best answer, okay? So pick two options. Okay, so popular answers are A, C, and E. Okay, so A, C, and E are the popular answers. So this is what's called a normal distribution curve. Luckily for us in medicine, a lot of what we measure falls into the normal distribution. And so a couple of things here is that you need to know some of the symbols so you can interpret it. So for example, you can see it's actually labeled, isn't it? So you can see this figure here, this is called mu, okay? This symbol here is called sigma. So this is mu plus 1 sigma. This is mu plus 2 sigma. This is mu plus 3 sigma. Sigma stands for standard deviation. You're given the standard deviation here is 5. And mu is for the mean in this context. So the first thing is that C is correct, that it's the mean weight was 65 because it's given here. Mean equals 65. This value here is the mean. So now the other part that we need to get, now in a multiple best answer in the AKT, you have to get it fully right to get 1 mark. So if you get one of these right and one wrong, you would get 0 marks in the exam. You don't get half a mark, okay? So what's the other one? Well, look, if the standard deviation is 5 kilograms, then knowing that the 95% confidence interval is 2 standard deviations above and below. I look 1, 2 standard deviations above, 1, 2 standard deviations below. That gives us 95% of the data. 95% of patients will weigh somewhere between here and here. So what is that value? Well, look, if standard deviation, if sigma is 5, 2 standard deviations will be what? Simply 5 times 2. Okay, so this is 65. 5 times 2 is 10. So the correct answer is between 55 and 75. Can you see, if this is going to be 65, if we take away 2 times 5 kilograms, which is 10, that's going to be 55. If we add 10, that's going to be 75. So between 55 and 75 kilograms, 95% of our patients are going to weigh somewhere in between that range. So I'll just go through the maths with you, okay? So the first thing is you have to know that the 95% confidence interval, which is what this question is testing your knowledge of, is the mean, so this is the mean, plus 2 standard deviations and minus 2 standard deviations, i.e. between here and here. Now, if 1 standard deviation is 5 kilograms, you see 2 standard deviations will be 10. So 65 plus 10 is 75, that gives us the higher number. 65 minus 10, that's 55, that gives us the lower number. So this is 55 kilograms, this is 75 kilograms, this is 65 kilograms. So that's why it's E. And it's C, that's again, you have to just know that mu means the mean, not the median, not the mode. Okay, so this is standard deviation. Okay, so mu is the mean, Sigma is standard deviation. If you go one standard deviation above and below, you get just over 2/3, actually 68% of the data. If you go 2 standard deviations above and below the mean, you get just over 95% of the data. We call this the 95% confidence interval. If you go 3 standard deviations above and below the mean, you get more than 99% of the data, but we call this the 99% confidence interval. Okay, so that's standard deviation. Right, last one we're going to look at is the admin domain. Okay, here we go. Thanks very much. I'll stop you there. So popular answers are C, E, and F. Okay, so C, E, and F. Has anyone seen one of these before? This is called the International Certificate of Yellow Fever Vaccination. Okay, in many countries throughout the world, there's a standardized form. Like each country has their own version. Okay, but it's recognized internationally. There's certain countries that before you're allowed to enter them, if they've got high risk of yellow fever, you might need to show a certificate. In some countries, if you're traveling from a country where there's high levels of yellow fever, that in order for you to go into certain countries from a high risk area, you have to have one of these certificates, otherwise they won't let you in. Okay, so if we look at the question, in any picture question, it's important to look at both the picture and the scenario. So if you look at the picture here, there's a clue here that this is the bit in red. But then if we read it here, you've got someone that wants a yellow fever vaccination and a certificate for travel. And it's asking what's the correct way to complete the box marked in red. So relating to certificate validity, i.e. this bit here. Okay, so you can see the rest have been filled in: patient's name, date of birth, gender, nationality, some kind of ID, their signature, what it's for, yellow fever. And then here, this is how you fill in the actual form. So yellow fever, this is the date that they had the vaccination. That goes here. This is the signature and the qualifications or job role, professional status of the person doing the vaccination. Okay, and then this is the lot number or sort of batch number for the vaccination. And so what goes in here, you put valid from date and a valid to date. Okay, so the correct answer is F. Okay, and I can see a quarter of you got that right. The most popular answers were actually C and E. So a lot of people thought that it was valid for 10 years and valid from the date that it's been signed. And a lot of people thought E, that it was valid for life, but from the date it's been signed, from the 10th March. Okay, so, and then this was just beyond that. Okay, so the validity of yellow fever vaccination certificate is 10 days after you have the vaccine. So if you have the vaccine on the 10th, it's valid from the 20th. Why? To allow 10 days for seroconversion. i.e., if you had the vaccine today and you have to have a valid certificate, your certificate won't be valid for 10 days. You couldn't travel tomorrow and the certificate be accepted because it's not valid yet. Why? Because you're not going to have immunity. You need 10 days for seroconversion. That's why the valid from date is always 10 days after for yellow fever. Okay, so it's valid from then. And then the validity is valid for life. So you could put here until life of person vaccinated, or just life, or lifetime, or indefinite. Any of those are fine. I'm just highlighting there's no end date to validity. There's just a start date, which is 10 days after. Now, in the old guidelines, the validity used to be for 10 years. So some of you that picked, 20th March and 10 days, D, that wasn't many people. But in the old guideline, that would have been right. It used to be 10 years validity. It was never 5 years. So yellow fever vaccination is one of those that's not available under the NHS. There's only one vaccine licensed in the UK. It's called Stamaril. It gives lifelong immunity. It is a live vaccine, so you should avoid it in someone who's immunocompromised. And recent MHRA alert highlighted that patients with thymus dysfunction, they can have a fatal reaction to this, so it needs to be avoided. And some countries, you have to have this international certificate of yellow fever vaccination. So you need to get that from a designated yellow fever center. It's valid 10 days after the vaccination is given to allow seroconversion, and it's valid for life. So other key areas for travel medicine that's worth knowing for your exam: malaria prophylaxis and treatment regimes, meningitis ACWY as a travel vaccine, diarrheal illness, and sort of how to manage those. Okay, right. So we've covered some stats, some admin, some clinical. So the next 6 eMedica AKT events. For those of you in East of England deanery, we're running our full day AKT course, the one that we ran on Saturday. We're running on behalf of Health Education East of England. So if you're in East of England deanery, you could contact the deanery and you might still be able to get on the list. That's on Monday all day. Then we've got a free high yield revision webinar on the 31st of March. Okay, so that's next Wednesday from 8 p.m. till 9:15. We'll cover 15. We've done 3 questions. We'll do 15 questions. So we'll do 5 like this one at a time. Then we'll do 10 as a timed mini mock and do teaching. And they're all high yield topics. And we'll also cover revision planning for the last 3 weeks for those of you sitting in April. And then our big webinars, stats, the 6th of April, all the key stats topics in 3.5 hours, 7 p.m. till 10:30. So that's not next week, the week after on Tuesday. Admin, all the key admin topics that you need to pass AKT, that's on the 7th of April, that's the Wednesday, again, 7 p.m. till 10:30 p.m. And then high yield clinical. All of the clinical topics examiners mentioned in their feedback report from the last 10 years. These topics come up again and again and again. So that's the 8th of April. And again, that's 7 p.m. till 10:30. And then our AKT 200 question mock crammer on the 10th of April. It's a full day from 9 o'clock till sort of 6:35. We will cover 200 questions and revise the relevant guidance for 200 topics, 160 clinical, 20 stats, 20 admin, and you get access to a full 200 question online mock afterwards. That one we're actually running on with RCGP Beds and Hearts as a national revision course. So if you want to book just the AKT 200, you can go to the RCGP website, look at their RCA and AKT preparation courses, and you can click here and book it. You can see that's on the 10th of April. If you want to book all of them, we have what's called our AKT booster bundle. That's basically over 25 hours of learning for the last few weeks. Okay, so it's those 3 webinars, stats, admin, clinical, 3.5 hours each. The AKT 200 mock crammer full day course, a full 200 question online mock. So we'll cover over 500 topics. All of the webinars come with PDF booklets, concise notes so you could revise efficiently. It's a real good way to boost all your score. So that's already discounted. If you were to book all of that separately, it would cost more than £530. But I'll show you. If you go to our website, AKT section, go to the AKT 200, the booster bundles at the top. So that's already discounted. So that's AKT. And we also have our AKT online revision, over 2,000 questions. And then if you want to rapidly revise a whole load of clinical guidelines, we've got our 2021 guidelines. So up to date, you can see things like these were only added to the notifiable disease list, COVID-19, SARS-CoV very recently. These are the latest impetigo guidelines, things like that. So, pocket size, you can read them in clinic, read them on the train. Just do a couple a day between now and the exam. You'll have covered 112 topics without realizing. So I'm going to move on to RCA update and consultation skills now. And then last section, we're going to talk about GP trainee money. So at a recent RCGP council meeting, the RCA was discussed. And what they discussed is that the RCA is going to continue, because a lot of people weren't sure what's going to happen. Because if you look on the RCGP website, you can see the only exam date for RCA that's available now is the May one. The March one is happening now, but the May one is the last submission that they've got dates for. So people weren't sure what's going to happen after that. So what has been discussed at the latest council meeting is that the RCA will continue all the rest of 2021 and until probably middle to sort of late 2022. Okay, it will then not revert back to CSA. It will be replaced by a new exam. And what they're talking about is a hybrid exam, that some of it would be recordings of real consultations like the RCA, part RCA. Some of it will be standardized with simulated patients, probably done remotely, but in a way that they can then make sure that you can handle certain high challenge cases, certain cases that you might not see day to day in practice, okay, to allow some more standardization. So some kind of hybrid, part CSA, part RCA, hopefully take the best things out of both of them. Now, to develop a new exam, pilot it, get it approved by the not just the Royal College, but the GMC as an exit exam. All of that takes time. So that's why the exact details haven't been confirmed, but development has already started. A group has been tasked. They've already started, doing the work of this, but it's going to be started to be piloted later this year and early next year. So what does that mean for you? Essentially, it means that if your CCT is before or on August 2022, you're going to do the RCA. If it's after that, you're probably going to be looking at this new hybrid exam. We don't have any more details of that. Beyond that, it's likely to be part CSA, part RCA. So, those of you that are in ST1, for example, those of you that are maybe in ST2, but you're less than full-time, so you might not CCT till end of 2022 or early 2023, you're probably going to sit the new exam. But those of you who are about to go into ST3 or already in ST3 and you're less than full-time and you're going to finish sometime later this year or early next year, you're going to do the RCA. So hopefully it gives you a bit more clarity as to what you need to be working towards and how to start preparing, that you don't need to wait. And then another question a lot of doctors have asked is, will there be an RCA sitting in this summer? Because usually there aren't exams in the summer. Last year there were, because a lot of things were cancelled because of COVID, right? The Royal College has said that they will decide and publish that at the beginning of April. By April the 8th, we'll know if the next sitting will be September, October, or whether there might be one in the summer. Okay, so watch out for that on the Royal College website. Okay. Right, so let's do some consultation skills now. And a really important skill, if you're going to explain a new diagnosis to a patient, or a new clinical term, it might be a test they're going for, it might be a diagnosis, something like that. But if it's something that's new to them, or if it's complex, that sometimes what really helps is just to break it down into smaller bits that are easier. So think about the 3 S's. Separate out the words, simplify each word, and then finish with summarizing how it all fits together with them. Let me give you some examples, okay? We'll do 2. So here's an example. You've got a lady, actually, if you go back to the example of someone with irregular periods, okay, that patient was 46 and they had vasomotor symptoms. Imagine you had someone who came to you because their periods were irregular. That was their main presenting complaint. And they said that, sometimes they go 2 months without a period. Sometimes they have a period after 6 weeks. Sometimes it'll come 7 weeks. And when it does come, it's really, really light. And then that's their main concern, is just about their periods. But you start taking a bit more history, and it turns out that they've also been really struggling with their weight, that they've had some acne. You examine their acne, you notice they've actually got a little bit of hirsutism on their face. And you start thinking, this could fit with PCOS. Now, you see, if you're trying to explain that to a patient, especially they came just to talk about their periods, and they were looking for maybe a fix, maybe starting the pill or something like that might help regulate their periods, okay? How would you explain a new diagnosis of suspected PCOS? Let's say, you're just explaining that it might be this. Or even if you had a different case where you've done the tests, they've had ultrasound, they've had all the blood tests, and it comes back and you've confirmed it. Either way, how would you explain that concept of PCOS to a patient? Type into the chat how you might explain something like that. Have a think. How might you explain a suspected diagnosis or a new diagnosis of polycystic ovarian syndrome? So it's a big mouthful, right? It's a complex term, and it might really confuse a lot of patients. Okay, so someone said that they might explain that it's a hormonal imbalance. Okay, so absolutely there is, changes in hormones. Someone said that your ovaries go into overdrive and prepare to release many eggs. Again, that's strictly true, but it still might be a bit complex for patients to understand. Someone said that you've got cysts on your ovaries caused by hormonal imbalance. Again, you see that while we will understand that that's medically correct, for a lot of patients, they might not understand what a cyst is. All right. Ovaries have cysts, so hormonal imbalances can cause multiple symptoms. Now we're getting a bit more of it, and it's getting there, but it still might not be clear to patients. Now let me show you an example how we could use this concept of a framework, the 3 S's: separate, simplify, summarize. Okay, so I've just talked to that patient. I've explained all their symptoms, I've examined them, and I'm now going to explain what I think it could be by separating each of these letters, PCOS, i.e. each of the words in polycystic ovarian syndrome, okay? I'm going to separate them out. Then I'm going to simplify what they each mean, and then I'm going to summarize how it links into them to make it real to the patient. So from what you've described, the fact that you've had irregular periods, I know that was your main concern, but because you've also got some other things, some changes to your skin, some hair growth, you've been struggling with your weight. When we put all of that together, you might have a condition that we call polycystic ovarian syndrome. Now that might sound complex. Let me just explain that a bit more clearly. So poly means many. A cyst is a clear sac filled with fluid, and we get these sometimes in the body, and they come and they go, and often they don't cause a problem. Sometimes you can get a cyst, a clear sac filled with fluid, near or on your ovaries. Your ovaries are what produce eggs, and usually if you have a regular cycle, if you produce an egg and you don't become pregnant, that's when you have a period, okay? Now, sometimes you can get some really big cysts, or you can get lots of cysts on one or both of your ovaries, and that can affect the hormones. Hormones are chemicals, and your ovaries, they regulate lots of hormones that can affect different parts of the body. So if there's lots of cysts or big cysts on your ovaries, it can cause an imbalance in the hormones that your body's producing. You can produce more of some, less of others, and that can affect lots of different parts of the body. And that's why we call it a syndrome. A syndrome means where different things are affected. It can affect your skin, for example, and cause hair growth. It can cause acne. It can affect weight and make it more difficult to lose weight. It can affect your periods. And that's why we call it polycystic ovarian syndrome. So to summarize, it means that there may be lots of cysts or big cysts on your ovaries. And because that can then affect the hormones that your body pumps out, it can affect lots of different things, causing a syndrome, i.e. lots of different problems at the same time. Now, how we can confirm it is we can do some blood tests to look for those hormones, and we can also do a jelly scan, an ultrasound scan, to see are there lots of cysts or are there big cysts on your ovary. Do you see how we've just broken down each word, okay? So that we can actually explain it to them. So we've separated each of the terms, simplified them, and then summarized it by linking it back to the patient. Okay. Right. Let's do another one. How might you explain a new diagnosis of benign prostatic hyperplasia? So let's say you've got a gentleman in their late 50s, and they've come to you with some, urinary tract symptoms. They're having some dribbling, some problems, sort of getting a proper stream going. You've examined them. It looks like their prostate is smooth. It's not craggy, but it is enlarged. They've got no red flags, nothing that makes you think that it's likely to be a cancer. Maybe you've even done some tests. Maybe you've done a PSA and it's all come back, So you've got a diagnosis of benign prostatic hyperplasia. Again, how might we explain that? Okay, so some good suggestions there. So someone said that a non-cancerous enlargement of the prostate. Someone said the gland around the neck of your urinary bladder has enlarged, causing these symptoms. Okay, a large prostate. Okay. Someone said that they just had that today. So yeah, great. So again, you could do the same process, couldn't you? All right. Simplify, separate out, then simplify, then summarize how it links to them. So if we look at each word, look, from what you've described and having examined you, it looks like you might have what we call benign prostatic hyperplasia. I'll just explain what that means. Benign just means that it's not cancerous. And from both the examination and the fact that you didn't have any blood, you've not had any weight loss, you've not had any bone pain, and nothing else that makes us worry, this doesn't fit with, because you can get a prostate cancer, it doesn't fit with that. Prostatic just means to do with your prostate. So your prostate is a gland that sits around the neck of your, sort of where your bladder is. And if it gets enlarged, it can cause some of the problems you've described, that you have difficulties when you're peeing. Sometimes it's a weak stream. Sometimes there's some dribbling, things like that. And hyperplasia is just a long word that means enlarged. So you've got a big prostate. It's got bigger than it should be. And that, because of that, it's causing some of these problems you're having. But it doesn't, the good news is it doesn't look like it's cancerous. Now, of course, the symptoms, the problems are still bothering you. And so there are things that we can do to help you to treat those things. But I just wanted to reassure you that this doesn't look like it's cancerous. So again, do you see, just broken down each word, all right? So, that it's enlarged, okay? That it's to do with the prostate, and that it's not cancerous. And you could use the same thing for lots of other things, okay? Just break down each word, simplify it, and then summarize so it links back and makes it real to them. Okay, so hope that's useful, in your sort of everyday consulting, but very useful, again, when you're doing explanations and you're trying to record a consultation for RCA as part of your interpersonal skills. Okay, and in terms of those that do want to prepare for our RCA, we do have our RCA Master Class, which is like a half day. There's a recorded version. It includes exactly how examiners are going to mark your cases, why do people fail and how can you avoid them, tips to get good quality recordings, how to deal with, choosing which cases, the sanctions for not having the right type of cases, things like that. And then our intensive full day course, which includes 25 role plays in one day with simulators, with detailed individual feedback. We had the last one of those for the May exam was actually earlier this month. The next one will be May onwards for people planning for whether they have it in the summer or after. Once we know that, in the beginning of April, we'll have some dates. Okay, and we take just 9 doctors, and for 9 doctors there'll be myself, another trainer, and there'll be 2 simulators, a male simulator and a female simulator. What it means is that everyone gets lots of practice, they get to see lots of cases, they get lots of individual feedback, and it's detailed feedback. Okay, great. So last session, and then we'll do a Q&A. So if you've got any questions, you can ask them in the Q&A. If they've not been cleared by the team, I'll clear them at the end. I just want to talk to you about trainee money matters. All right, so how can you increase your take-home pay? So I appreciate, during training years, finances can be tight. You often don't want to do too many additional locums because you're so busy. You've got so many other things to do, keeping up with your workplace-based assessment, you're preparing for your exams, that, if there were ways that you could have more money in your pocket without having to do shifts, that would be better, wouldn't it? Because yes, if you need to do the odd locum, you can do it. But if you had to do it regularly, it might start impacting and causing problems with you being able to manage everything else in your training. Okay, so let's look at 5 ways that you can increase your take-home pay without actually doing any more work. All right. So the 5 are claiming all your tax allowances, claiming all the expenses that you're able to claim during training, making the most use of things that you're already subscribed to or paying for, getting cash back either from the government or privately, okay, and then making use of, taking advantage of discounts that are available to NHS workers or healthcare workers and other benefits, okay. So I'll go through each of these in a bit more detail. So the first is claiming all your tax allowances. So I know a lot of doctors in training have never sort of claimed any tax allowances, so they don't realize that they could actually get some of this money back. So for example, your annual GMC fee, if you're a BMA member, your BMA subscription, if you're, and most of you are associates in training with the RCGP, so you paid your initial membership fee and then every year you pay an annual fee, okay? Indemnity, I know indemnity now for most of you is covered by the deanery directly, but some of you might still be paying a small amount, okay? All of these things, you can claim the tax element back again, okay? Essentially what happens is your tax allowance is increased to give you a rebate. So if you're a lower rate taxpayer, what it means is you're getting 20% back. If you're a higher rate taxpayer, which if you're an ST3, a lot of you will be, then you'll be getting 40% essentially back of what you've paid. Your exam fees for MRCGP, so the fee that you pay for the actual exam, you cannot as a trainee claim money from the government. You can't claim against tax for any courses that you do. Of course, you may be able to claim your courses from your study budget, from the deanery, but the actual cost of the exam, paying for the AKT, it's £450, paying for the RCA, so 800 and something pounds, okay? When it was CSA, it used to be like, £1,200 or whatever. The actual exam fees, you can claim back, okay? Replacement medical equipment, you can't claim again as a trainee for new equipment that you buy. So let's say now you don't own an otoscope and you want to buy an otoscope and ophthalmoscope, you can't claim tax on that. But if you've got a stethoscope and the tube broke and you're going to buy a replacement stethoscope, you can claim tax against the cost of that. And the ways that you can do that, you can either go to the government website and set up a personal tax account, very straightforward to do. And then you can just put in there the allowances that you want to claim, okay? And then they will adjust your tax code and you can check your tax code. You can see what your tax bill is going to be or your tax liability is going to be. Or if you're going to be claiming less than £2,500 worth of expenses, then you can either fill in a form called Form P87, or you can just write to HMRC or just phone them. They're really helpful, and just tell them, look, this is my national insurance number, so they can locate your tax account. Tell them what you're trying to claim for, and they'll help you how to do it, okay? If you're going to claim for more than £2,500 worth in one tax year, which very few of you are going to do, okay? Sometimes it happens in the final year. Then you need to fill in a self-assessment tax return, okay? You can't just do that on the P87 if it's above 2,500. Right, so all of these things you could claim, and so that could be several £100s worth of money, if you like, that you're not paying tax on, effectively getting back. Okay. The other thing that some of you will be doing some of this, but maybe some of you don't do all of it, is to claim expenses. So for example, when you're in GP, you can claim expenses for all business mileage. So business mileage is like when you do home visits. You can see when you go on a study day, at the moment, I appreciate everything's remote, so you can't really claim for travel to study days because you're doing it from home in most cases. But on the other side, you're not paying the money to spend on the fuel, are you? Right? So it balances out. But like when we used to go and do study days, like an away day, it's not at your normal place. The cost of travel, the mileage you could claim back. Excess mileage. Your first rotation when you start training is considered your base site. So let's say, for example, your first rotation. I'll give you an example. Right? I live in Solihull. Let's say my first rotation was in Solihull Hospital. I mean, I trained in Neathport Talbot, actually. I'll give you my example. I trained in Neathport Talbot. So my first job was in Neath, okay? But after that, I did hospital jobs in Royal Glamorgan. So if my first site is considered my base, Neath, let's say that's 10 miles from my house. And let's say my second rotation is 15 miles. I can claim the difference. I can claim 5 miles as excess mileage. In some cases, if you live quite far from where your base is and you didn't move, in some cases, you might be able to claim mileage. What you need to do for all of these things is check the local policy. Each deanery uses their own system. In most cases, you'll either go through the deanery or the lead employer, but they will tell you how many miles, before you can claim excess mileage. What is the policy? How do you do it? In some of them, you fill it in online. Some of them, there's a paper form. Start tracking your business mileage and then claim for it. Over a period of a year, it could be several £100s. Okay, so check your local policy. Similarly, relocation. Those of you that moved to start your rotation, and I know some of you haven't started training yet, and you're going to be starting training soon. But, if you move from one deanery to another, then the actual cost of the removal van, things like that. If you are selling one property in one area and you move to a new property and you buy a new property there, things like some of the agents' fees, some of the cost of the survey, stamp duty, things like that can be in the relocation policy. Again, each area has their own. So the answer to specific questions, can I do this, this, or this, is check your local policy. Contact them and ask them. Okay. Make the most use of things you're already paying for. So for example, all of you are, or most of you are members of the RCGP Associate in Training. Okay, you're associate members of the Royal College. As part of that subscription, you get access to the GP self-test, which is really useful for AKT. On top of that, being an associate in training as a member of the RCGP while in training, you're considered that while you're in training, you're considered eligible for a student discount if you pay for the TakeHome card. So the TakeHome card usually is for university students. But the Royal College, for people who are associates in training, is recognized as a professional body because, if you like, you are engaged in training. We know you're not actually a student. So for example, you couldn't claim discounts on your council tax because you're not actually a student. But you can legitimately apply for a TakeHome card. So this can give you discounts on, like shopping, food at different restaurants, things like, eventually when things open up again, clothes shops. You do have to pay for this card. It's about £36 for 3 years. But if you're going to be buying some of these things anyway, saving 10 or 15% in some cases over a period of 3 years while you're in training, it can add up, because usually as doctors, we wouldn't be entitled to student discounts. Okay, but with this, you can access a lot of student discounts in a lot of places. A lot of you are members of the BMA. If you're a member of the BMA, one of the brilliant services they have is they have a library service. And, like buying textbooks when you're in different rotations, or if you're trying to get books to prepare for AKT or RCA or CSA, it can add up to hundreds of pounds. But you don't need to buy them because you're usually going to use them for a few months and then not need them. You can borrow them. They've got huge range of books. So if you're a BMA member, you can log into the library. You can request, I want this book, this book, this book, and you can borrow it for a month. If no one else has requested it, you can renew it again. They pay for the postage. You don't pay anything to have it. All you've got to do is pay to post it back. So if you put them in one packet, one box and post it back, it might cost you, I don't know, £5–10 to borrow books for a couple of months. That if you bought those books, you might spend £200–300, okay, buying all those books, right? So, if you're going to a new rotation and you wanted to get a textbook to help you, sort of get familiar with some of the things for that, or if you're preparing for your exams, rather than buying some of these things, you could borrow them, right? And then some of you will have indemnity with MPS. If you're an MPS member, they offer some fantastic, very high quality training on things that will help you, not just for training, but as a qualified GP. I've been on some of this training. Now, because I teach a lot, when I go to training elsewhere, one of the things I look at is, what was the process like? What are the quality of the materials? What was the quality of the presenter? And I was really, really impressed. The consultants and GPs that are doing the training for MPS, they're fantastic, very experienced clinicians, but they're all been selected because they've also got experience in teaching. Okay, so you can get training on things like how to prevent complaints, how to deal with difficult encounters, angry patients, patient that is demanding things that are inappropriate, patient who's addicted to medications and doesn't want to wean off them, how to make good entries into the record so that if someone complains, you're defensible, how to prescribe safely, things like this. It's really useful CPD. These courses will be like £200 for half a day. If you weren't a member, it's completely free. You don't even have to pay a booking fee if you're a member. So if you're a member, go on them. You could access £1,000 worth of training while you're in training for free. So they've got, training on all of these things. Also, MPS members can get discounts on any of our courses and online services because they've been partnering with us for like 15 years. Okay. Get cash back. So a couple of ways you can do this. So one is get some money back from the government. All right. So as well as, claiming all the allowances we talked about, but things like tax-free childcare. So you can claim up to £2,000 per child, £2,000 per child per year towards childcare. To do this, both partners must be working, and they must both, like each person has to earn less than £100,000. But for most people in training, that's the case, isn't it? Okay. And so as long as you're able to access public funds, because I know some of you are on a visa that won't allow you to access public funds, but otherwise what essentially what happens is you set up a tax-free childcare account, and you could put in, let's say you put in £800, the government will top it up with £200. Okay, so you could put in up to £8,000 in a year. I appreciate most of you aren't going to be spending that much on childcare, but sometimes people are spending a lot of money on childcare. So as long as they are Ofsted accredited, so you can use this, for example, for a childminder, a childcare service, an Ofsted registered, nanny or daycare service. When these things open, even for things like private schools, you can't pay for the actual schooling. But for example, if they've got after school clubs where there's a childcare element, you can pay for that using this. And, essentially they top up. So you're getting like a 20% discount. All right. So, you can claim for that. And then cashback sites. So the two big ones are Top Cashback and Quidco. So if you're going to be buying something anyway, okay, then you can essentially look for, I'll show you. This is Top Cashback, which is the one that I use, okay? Let's say now you need to renew your car insurance. It's that time of year, okay? So you type in car insurance, okay? Don't go on there for something that you don't want to buy. Don't waste money. But if you're going to buy it anyway, so let's say now, for example, you're going to get car insurance. You could find whichever one you're going to go with anyway. Let's say you were going to get a Viva car because you already ran one of these, market comparison things, and it came up the cheapest. But you just click through here, okay? It tells you if you're getting a single car policy, they'll give you £80, right? Click the button, get cash back. It says, oh, there we are, we've registered it now. It will take you to the website, but through a special link. You now just, as normal, get your quote, get your cover, and then a few months later, they'll give you £80. i.e., you're going to buy it anyway, still find the one which is going to be cheaper for you. But it's like free money. Like I've used this every year, but I have to buy insurance for the car anyway, right? So, let's say my car insurance is £400. If I can get £80 back, I've only paid £320 effectively. Okay, and then when you get that money back, you can either take it into your bank account, or you can get Amazon vouchers, or do whatever, treat yourself, or treat your kids, treat your partner, do something nice. So the two big ones are Top Cashback and Quidco. Okay, I'll send you the links where you can sign up to all of these in a minute. In fact, and then last thing is NHS discounts and benefits. Okay, so some of you might not want to get the totem card because you have to pay for that, and you think, I don't buy enough of those things that I'm going to save money. So you might apply for the blue light card, which is cheaper. And that again is like for healthcare workers, it can give discounts on some things. It doesn't give discounts to as many things as the totem card does, but there's still a lot of things where you can get discount. And then a lot of organizations advertise discounts, and especially with the pandemic, we've had the 1-year anniversary right recently. There's a lot more things that a lot of companies that now are willing to give discounts to healthcare workers because they appreciate all the hard work that we've been doing. So things, again, don't go and buy something you don't need to get the discount. That's the wrong way to look at it. But let's say you were going to get a new contract with Vodafone anyway. They offer a discount for NHS. If you're going to get a contract for EE anyway, they offer a discount. Apple for buying some of their devices, Nando's, various restaurants, Leon, for example, offer. And sometimes things just not advertised. Just ask. If you got your NHS card, some kind of ID, just ask. Do you offer a discount for healthcare workers? Do you offer a discount for NHS? You never know. I'll give you a real example. I was in clinic on last time I was in clinic, it was like Wednesday, right? I finished clinic and I hadn't had time for a proper breakfast, and I was really, really hungry, and so I just really fancied something different. So I just really fancied. I don't know if any of you have been to German doner kebab. Have you been there? So they do like a meat doner, or they do like a chicken doner. They're both really nice. But anyway, there's a German doner kebab that is sort of on the way home. I have to take a slight diversion. So I went in there, and that's what I was going to get anyway. And they don't have any signs about NHS discount, but I just thought I'd ask because I was coming back from work. I said, "Oh, do you do any discounts?" And they said, "Oh yeah, if you can show any ID." So I had my NHS smart card that I use, and they said, "Oh yeah," and they just knocked 15% off. You see, so you never know. Just ask, okay? And then, like, if for example you wanted to look up some research, things like that, you can access journals through NHS Athens. You can all apply for an NHS Athens account with an NHS email. So you can access journals because sometimes if you don't have access to a journal and you want to read something, they charge like £20 for one article. You can access the majority of journals through the NHS Athens. And there's also free e-learning. So for example, towards the end of your training, you will need to be up to date with things like adult safeguarding, child safeguarding, information governance, things like that. A lot of this you can access for free on e-learning for healthcare. So rather than paying for it from a different firm, the NHS is already funding it. Get it from there. Oh, sorry, that tells me that's time, and we're actually about time. So just to summarize, look, if you can save money, it's a lot more efficient than earning extra, because first of all, if you earn extra, you've got to put more hours in. But secondly, you then got to pay tax, national insurance, pension contribution on that. Whereas if you save money or get cash back, okay, in most cases, that's not stuff that you have to then pay tax on, national insurance on, because it's a refund or a rebate, okay? Claim all of your allowances and expenses that you sort of can do, because they're the legitimate ones that you've incurred, and maximize what you already have and what you already have access to, okay? So links to more details about, and where you can find the P87 or the tax account I was talking about, all of those things, where you can find all of that. The links for the 2 cashback sites I mentioned. So this is the article. Okay, it's actually got more ways. We talked about 5 years. It's got 9 ways you can save money as a junior doctor, and it's got links to all of those things that I talked about. Okay, so you feel free to use that. And I'm just going to try and clear some of the questions. All right. So someone's asked, as an ST2 after AKT, can they do locum in out of hours? No, you have to be a qualified GP to work in out of hours. Someone's asked, if you're granted an extension of training, are you still eligible for the totem card? That's a good question. I don't know. I would imagine so, because you're still in training. What you might need to do though is pay, because the totem card is a fee for 3 years. So you might need to renew it again. Okay. Someone asked, can you claim tax relief if you're on a visa like tier 2? Yes. So things like for your GMC, RCGP, BMA, that's not considered public funds. That's a legitimate tax deduction. You can claim that, that's fine. What you can't claim if you're on a visa that says no access to public funds is things like tax-free childcare. That's considered public funds. You wouldn't be eligible for things like that. I was asked, when will the AKT exams for October be advertised? So they probably won't start advertising those till summertime, but it's usually the last Wednesday of October, okay, the October exam. Someone asked, is the AKT tax deductible? Yes, all the MRCGP exams are, but you cannot as a trainee claim for courses against tax. You can claim for a course in some cases from your study budget, from your deanery, but that's nothing to do with the tax man. As an employee, as a trainee, you can't claim the cost of any courses. But the actual exam, because it's an exam you have to do in training, it's a requirement, isn't it, for you to complete your training to do MRCGP. That's why they're allowable. You can claim the cost of the actual AKT and the RCA or CSA. All right, you can claim both of those. Okay, great. So thanks very much, everyone. I hope you found it helpful today. I do hope to see some of you at some of the AKT events over the next few weeks, and I'll see some of you, for some of the other things. Those of you coming to the end of training, remember our CCT Plus course, Key Skills for New GPs, is going to be running in June. Those of you about to start training, our GPST Plus course for doctors about to start training on how to make the most of all 3 years, how to get through all your exams first time, how to prepare for each year of training and maximize it. That's also running in June. So thanks very much. I hope it's been helpful. Huge thank you to the eMedica team. Thank you so much for all your help and support throughout the day. And I'll see you all next month. Thank you so much. Have a great evening.